Hi, I'm Rui Pereira da Costa, organizer of the International Endomasters 2015, and here I am to introduce you the second part of a terrific presentation from Nicola Grande and Gianluca Plotino that'll explore one of the most challenging phases of the endodontic treatment. Many clinicians consider this to be the holy grail of all procedures, as it has a proved impact on the success or failure of the endo treatment. I'm talking about apical control, how to instrument this delicate and complex area, how to define how much should we enlarge it, are questions we all had at some point, and that Nick and Gianluca will answer. Not to be missed. I'm sure you'll enjoy.
So we need a technique to determine which is the correct dimension of our apical preparation to have a good mechanical contact and a good access with our irrigants. We can say that one of the reliable techniques that can give us many information on how much is our preparation and how efficient it is the so-called visual gauging. The visual gauging consists in look at the dentin debris on the instruments, and this is facilitated with the rotary night eye files because the debris and what we are cutting in the apical region remain stuffed on the instrument. So if we look at which kind of debris we have, we should have as ideal image a wide, clean and well represented amount of dentin that are packed inside the blades of the instrument, almost in our 2-3 millimeters of the apical portion of this instrument. So if we look at the tip of the instrument and there is not an amount of dentin well represented in the apical region after we have done the apical preparation, like in this situation that we was having with a rotary files that was working at the apex, we are completing the apical preparation under the control, the direct control of the apex locator. Once we arrive at the working length, we do a radiograph to check how our file is fitting in the apex. When we come out from the apical region, we see that the dentin that we have there is not well represented. So this is an important information that make us to take the decision to increase the apical dimension because the instrument size is smaller of what is needed to real contact the dentinal walls and cut dentin in the apical area. So our decision that we take in these situations is to increase the size of apical preparation. The same situation can be when there is a presence of red dentin on the apical blades of the instrument. This can mean that there is a presence of vital pulp in the apical region and still we have to enlarge the dimension of the root canal. Moreover, we can have some other situation in which we have dentin, especially in necrotic cases. We have an amount of dentin in the apical area of the instrument during the apical preparation again, but the dentin that we cut is brown or yellow, so it's colored, and this can mean that still there are bacteria engaged in the dentinal tubules that we are contacting with our instruments. Even in this case, if there is a presence of infected dentin in the apical region, we have to increase more our apical preparation. When the dentin is not enough, as we have seen in the video, of course we have to increase again our apical preparation. Like in this retreatment, we have seen that we were arriving over the material, we were contacting the root canal wall in this area, but probably this color of dentin that is a little bit black or brown means that there is not enough enlargement to create a good debridement of the apical region. So in this situation, even we will increase the size of the apical preparation a little bit more. The ideal goal will be the one when we have enough dentin, like in this case, And going back to the clinical case we were seeing before, we increased the size of the instrument from a 25 to a 40, and we can see in this video that the dentin that we cut in that area is white. It is comprised in the last 3 millimeters, and it is well represented. So we can be satisfied of this apical preparation and retain and think that this is there is a contact circumferential on the last 3 millimeters of our instrument on the root canal walls. This can be one of the information that we can count on to believe that this is a correct size of apical preparation. What we see in the clinical cases is that if we follow this principle of visual gauging, our preparation will be always corresponding to what has been the ideal goal of our preparation. We have seen that even in the most difficult cases, we have to arrive to 30 or 40, or even more sometimes, even especially in retreatment. Usually we have to enlarge to a dimension that is over these dimensions of 30, 40. In vital case, the same. It depends on the dimension of the root canals, the age of the patient. Many variables should be taken in consideration. And we have to follow the principles that we have to touch 360 degrees with our instrument the root canal walls in the apical preparation. These are some cases in which of treatments, of primary treatment and retreatments, in which we have enlarged following the principle of the visual gauging. And again, the controls that give us the success over the years of the root canal treatments always depends on how it is the shape of the root canal. Even if we have an enlarged apical preparation, we can still have a good obturation technique with a three-dimensional injection of the gutta percha, adapting our obturation technique to the size and the shape of the preparation. These are some other cases in which was performed an apical preparation, and the restorations of the same cases and revisions at 1 year that demonstrate that it is possible to have a healing and to maintain the tooth in the mouth with performing an endodontic treatment that is predictable. This is a particular case in which after the removal of the post, it was a retreatment, we entered the root canals. The mesiobuccal root was not treated, while in the palatal root we had to remove a carrier of the thermophil. We can jump a little bit this part where we are creating the space around the carrier and then screwing up some headstrums on the side of the carrier, removing it. We go a little bit faster, the removal of the carrier, the removal of the rest of the material, the phases of the preparation, and let's go to see which is the apical preparation with this file that was a reciproc R25, and jumping to an instrument that is 40 taper 4, we can perform the apical gauging. This is what we can define a good apical visual gauging with the white dentin that was remaining well represented in the last 3 millimeters of the instrument, that of course it is less tapered of the instrument previous used, so we'll cut only in the apical portion. Let's go now fast on the preparation with a single instrument technique on the mesiobuccal. We see that in this case the file, after the apical scouting and preparation was remaining full of white dentin. So it was decided in the MB1, in this particular case, we see the final steps of the preparation performed under the control of the apex locator. And let's go to see, with a fine control, with reciprocating file, we can stop and go the instrument how much time we want, so to improve our control in the working length. And we see that at one point we will have the signal of the apex locator that is flashing and say to us which is the correct working length. We can control in this way even less than half of a millimeter. We see that this is what we see on the instrument, that is a white dentin, so the visual gauging was positive. Let's go fast a little bit with this case because there was the same action, the same preparation in the MB2 with a single instrument file, 25 taper 8 in the tip, and even in this root canal we decided to stop the preparation to a 25 taper 8. It is not so common because usually even in molars we tend to enlarge more, but in this case we retained it was enough. So going to the next slide, we will see that it was impossible to scout the distal root canal, while these were the working length in the MB root and in the palatal root. There was a false canal created by the previous treatment, so we decided to obturate the root canals. This is the obturation after the preparation that we have seen, and we did a CBCT to understand which was the situation of the distal root canal. Even here we can see that we had obturation on the false root canal created iatrogenically by the previous intervention. We see even that there was dilation that was around the distal root that was fused to the palatal. So in these cases we waited for 6 months, but the patient still had some symptoms. So we decided to go surgically. And this is the interesting thing, is that we can observe after the apicectomy of the mesial root, the 2 root canals that were prepared to size 25 that are perfectly round and well shaped by our instrument, contacting all the root canal walls. We can see even that was a presence of the apical region of just a tiny root canal in the distal root, the retroobturation, and we can see here that after the retroprep and retroobturation, the symptoms of the patient healed and resolved, and we had a good healing. We are having a good healing.
Thank you very much, Nick, for sharing this beautiful case in which everything was very, very clear and evident on the quality of this preparation after apical surgery. There are some cases clinically instead in which we can have some more difficulties with a difficult physiological anatomy and a difficult scouting on this anatomy. Every one of us in our clinical experience has appreciated some cases in which we are not able to scout and to negotiate all the root canals until the apex. We stay there several minutes, half an hour, changing a lot of hand instruments, size 6, 8, 10, trying to scout the apical anatomy, and sometimes it is almost impossible. So there are some cases of difficult scouting, like this lower molar, with which we must deal and with which we must change a little bit our treatment protocols. In this case, for example, it was almost impossible to gain this apical portion of the distal root and also this apical portion in the mesial root because of something difficult there by an anatomical point of view. So what we do in this case is
where we cannot perform an extended apical enlargement, an extended apical preparation as we want to deliver our irrigants there, we try to increase the delivery of our irrigating solutions with ultrasonic power and other devices that we have in our disposal. In this case, for example, in the distal root canal, as you can see, we are using an active ultrasonic tip that is a K file on the ultrasonic power, because it is more active than the passive file that normally is used for the ultrasonic irrigation. With this purpose, we try to move the irrigant more and more in the apical area to permit the debridement and the cleaning of these areas, and trying to fill them even if there has not been a precise shaping of this area. We call these cases shapeless apical preparation, because we are not able to perform an apical shape of preparation where to fit a correct gutta-percha cone or a carrier-based technique. So in these cases, we try to move our irrigants far and far by activating it with several devices that we have at our disposal, trying to clean it as much as possible. Obviously, we prefer, when it is possible, to have a mechanical preparation of these areas, but sometimes we know it is almost impossible to negotiate the apical third of these root canals. This is another case very similar to the one that we have seen before, another lower molar with so long roots, more than 25 millimeters, and a particular aspect in the apical area where our hand instrument, even in small sizes, have so difficulties to arrive to prepare and to scout these areas. If we keep in our mind the micro CT reconstruction that we have already seen, we can now imagine why we have problems in this case to arrive to these areas, because probably there is a root canal anastomosis, there is an apical delta, there is some calcification, something in the anatomy that make impossible to our instrument to find the correct way to reach the apex. Even in this case, we did as much as possible with our hand instrumentation, staying minutes and minutes and minutes trying to scout these root canals, and we enhanced the time of the cleaning by using ultrasonic activation of the irrigants and apical negative pressure devices, so that to permit to our filling procedure to fill that area. Obviously, this is not the best that we want to do in regular cases, but it is the best that we can do in such difficult cases where we are not able to shape and to clean also mechanically these areas. This is the control of 1 year, and also if we have a small preparation and a small obturation because no shape has been given to this, the results even at 1 year they are good. There are some other anatomical situations in which we must keep attention and we must deal with, for example, in particularly complex anatomy. It's difficult to speak of particular complex anatomy after we have seen all these three-dimensional reconstruction where we can appreciate that all root canals are very difficult and present root canal complex anatomy, especially in the apical third. But there are some anatomical variations that we must deal with particular attention. For example, this three-dimensional reconstruction of a lower molar with a sort of fused root, C-shaped roots, but with the two separated root canals in the mesial root and one merging at the apex and one in the distal. So you can see by entering from the distal side of this root, look here. After the conjunction of the two mesial root canals, the anastomoses that are present and that finish in the inner part in the conjunction of the two roots and finish in the distal root. Look at here. So in these areas, probably our instruments have very difficulties to reach a particular way where to arrive, and they can stop there. So we can be unable to treat these areas because of these anatomical difficulties and these anatomical particular situations. This can be an example of these anatomical variations that we can find in our treatments. A lower premolar, usually the lower premolar, when they are normal, they are quite easy. One single big root canal, not so difficult to be treated. But when the lower premolar are difficult, they are probably the most difficult teeth in the mouth. Because as in this case, this lower premolar, you can also appreciate by the radiograph, the canal disappeared at one point. So something there will be there anatomically, even from a preoperative radiograph. In this case, we had three separated root canals in this lower premolar. So a difficult anatomy, especially because of their origin. Look at where they origin. It's so strict because of the shape of the anatomy of the root of the lower premolar. So the access is not so easy to be obtained to these root canals. And look at the two buccal root canals and one lingual. We are under the microscope using the specific instruments to try to scout these root canals manually first, and then also mechanically by rotary and reciprocating instruments. It's always difficult to deal with this anatomy, avoiding to damage the coronal structure. We must keep sound teeth as much as possible. So we went in with a small file in rotation for the creation of the glide path, and then the preparation with nickel titanium files. And look at the end, we will perform also we performed also the three-dimensional filling of these root canals as a regular case. But in this case, obviously, this is the final radiograph. In these cases, we must keep attention. Look at where one of the three root canals exit. And we must keep attention on this area and also on the middle and coronal third areas, because they are three separated root canals, but in these cases they are always merging themselves. So we must increase again the time of our irrigation in these canals, because the apical preparation cannot be so important in these small root canals, difficult root canals with difficult access. So when we have difficulties to treat the apical third correctly with the size that we think it's correct, we must increase something more the irrigation procedure to avoid to defeat what we have done less with the preparation. This is another three-dimensional reconstruction, a lower premolar that can resemble the one of that we have seen before clinically. This is a lower premolar, a sort of C-shaped lower premolar. Look at the anastomosis, three canals, the one that finish in the furcation, the two root canals that goes to the apex with an apical ending, two root canals separated. This can be a very nice micro-CT reconstruction of a case that are very similar to the one that we have seen. And look where we finish this root canal inside the furcation from this reconstruction, and look the other two root canals of this C-shaped lower premolar that arrives until the end with all the anastomosis. It's very, very difficult to deal with these anatomies, but we have to increase all our procedure to try to obtain the best from our treatment and to try to gain the success from our treatments. Obviously, the lower molar, C-shaped lower molars, they are always, they have always presence of communication in between the two main root canals that we have in this case, for example. We must never consider these root canals such different entities. They are always communicating through themselves. So after a proper preparation with mechanical instrument, after the proper choose of the cone, gutta-percha cone, and diagnosis of the merging of the two root canals, of the confluence of the two root canals, we have to increase the cleaning efficacy of our procedures, and it will increase the filling, the three-dimensional filling of the inaccessible areas in these cases. And this is another C-shaped mandibular molar in which it is very, very well evident after the removal of the gingival tissue, we gained the proper access cavity isolation with rubber dam and liquid dam. We prepared mechanically these root canals, and we prepared with ultrasonic tips specifically designed for this anatomy. And look at the postoperative radiograph. You can appreciate the two main root canals merging in one, filled by the gutta percha cones, and the anastomosis that has been, where has been the tissues and the debris have been removed during the procedures, and that were filled by a three-dimensional obturation technique. This is very important, and this is what we would like to see, because we must remove all the contents from this anatomical structure to permit our filling techniques to fill these areas. So we insist in these cases on an enhanced ultrasonic activation of sodium hypochlorite specifically. And we usually arrive with our endodontic needles to 1 millimeter short of the working length to deliver the irrigants. This is very, very important. Our irrigation protocol arises from the evidence that is present in the literature. And we like to share in this case the irrigation protocol and the disinfection protocol that we use usually in our clinical procedure, because together with the anatomical apical preparation, we like to perform an irrigation procedure to improve the disinfection and the debridement of our treatments. We use sodium hypochlorite in a high percentage, more than 5%, 5 to 6%, during all the instrumentation phase, using a lot of irrigants during the instrumentation phase and removing it and replacing it. We also use it heated because it seems that it's more functional in its work. At the end of the instrumentation, we use the ultrasonic activation of the irrigant, and we use the ultrasonic activation also during our instrumentation procedure. Each irrigation with a syringe, we use ultrasonic activation to prevent the accumulation of debris inside the root canal, especially if we are using single instrument techniques, single file techniques that tends to accumulate more and more debris. So use ultrasonic power as much as possible, even during the preparation phase. After the ultrasonic activation of the hypochlorite, we use also 17% EDTA to remove the inorganic content of the root canals and the smear layer. 2 minutes usually inside the root canals. In infected case, it can be used at 2% chlorhexidine, even if there are some studies that says that it can produce bioproducts when in contact with the other irrigants, especially sodium hypochlorite, and so this phase is doubtful today, but it can be, in infected case, an adjunct disinfection after the removal of smear layer to promote the chlorhexidine to arrive inside the dentinal tubules. So at this phase, I repeat, the studies say that can have some limitation. The apical negative pressure irrigation in selected cases is something that we do, and we have seen some cases before, because we consider it not an alternative to the ultrasonic activation, but the combination of both techniques may help us to obtain the best by our procedures. Sometimes we use also the light-activated disinfection, a disinfection activated by light, by irrigating with a photosensitizer inside the root canal that is activated by the light, and it has a very good and very nice antimicrobial effect. In very, very difficult cases, retreatment with persistent infection, we can add also this disinfection procedure. Then we love to remove everything with sterile saline solution and to use the pure alcohol to help us in the drying of the root canal before the obturation phase. So going back to the argument of the preparation, of the apical preparation, there are some cases in which it is almost impossible to obtain our main aim, that is a circumferential preparation until the apex. Because there are some cases in which we have limits due to the dimensions of the root canals at the apex and limits due to the irregular shape of this root canal at the apex. For example, this is a lower molar with a big unique root canal which exits with a very, very big dimension. So in a case like this, we can appreciate we have only an anastomosis that can be prepared, but a big apical exit in which we have to adapt a gutta percha cone to a particular size. And sometimes we cannot prepare more and more this apical portion. We must prepare as much as possible and then adapt again our irrigation procedure, adapting our obturation procedure. This is the concept. When we have an apical anatomy with a regular shape on so big root canals, we have to adapt our techniques, including irrigation and obturation techniques. Like in this upper premolar, the fact that these two canals merged at the apex gave to this apex such big dimension. This is an 80 sides gutta percha cone adapted to this dimension because it was not possible to enlarge more and more this apex, because the risk of destroying this root at the apex by increasing so much the apical size of preparation limit us in this phase. So we have to adapt our technique to obtain our results. This is the coronal filling of this case. We have published all this concept also in this study on the Journal of Oral and Maxillofacial Research on the influence of different apical preparation of human cleansers and human molars, giving this concept in this study. In these particular cases, the adaptation of the obturation technique with gutta percha must be done in an untapered preparation, because as in this upper central incisor, we removed all the old filling material by using our endodontic instrument and endodontic instrumentation. Then we performed our apical preparation by hand until instrument of big size of preparation, because here you can appreciate a size verifier number 70 to prepare this apex. Sometimes we have to, if we follow the concept of the visual gauging that Nick has shown to you before, we have to continue our preparation until big sizes that are bigger and bigger to encounter that properties. And in this case, we always like to use small tapered instruments to reduce the destroy of the tissues in the middle and coronal tiers of the root canal. And in this case, as you can appreciate also by this final radiograph, we have an almost untapered preparation in the apical portion in such cases like this, so with the lower taper. So we have to adapt our filling technique by using, for example, a classical Schilder technique instead of the continuous wave of condensation technique, because we have more control on this obturation in these cases. And look at here, we have controlled as much as possible the extrusion of the material that is not so easy in such big apical areas. Going on more and more on this concept, we are arriving at the end of this lecture. In the last part, we will show to you some cases in which we have to deal with the repair of the altered apical anatomy. Until now, we have seen the physiological anatomy, the physiological apical anatomy, and how to deal with this and with the root dimensions in the physiological situation. Now we would like to share to you some cases and some concepts when we have an apical root resorption, and that we can call a pathological anatomy. We always know that we have an apical root resorption in almost 100% of the cases in which we have a periapical pathosis, a periapical bone resorption. If we have bone resorption, we have also external root resorption at the apex. And if we look again at this clarification by Professor Ritano, if we have this anatomy in the last 1-2 millimeters of this root in a physiological situation, if we have a periapical pathosis and a periapical bone resorption, we will have a resorption of the apex, and we will lose also all this anatomy. So in these cases of resorbed apex, we have to deal with a completely destroyed anatomy. We must not deal anymore with the drawings that we know from the books, with the apical delta, the apical constriction, apical foramen, minor constriction. There are no more this anatomy in this teeth. We have to deal with destroyed apical anatomy in this resorbed apex. This micro-CT reconstruction can help us to understand this distal root has been resorbed by periapical pathosis, and after the extraction and the scanning we can appreciate how big they are, this root canal, and which is the shape, completely irregular shape, very different from a physiological anatomy like the one in the mesial root. With this you can recognize the minor foramen, the apical constriction, and then the major foramen at the outside of the root. Here we cannot appreciate all these stuffs. We must deal with a destroyed apical anatomy. And this is for this reason, again, that we have to deal with the limitation due to the dimension and to the irregular shape. But in this case, the irregular shape is due by the pathosis. So we have no more an anatomy to respect. But we can use our instruments more and more to enlarge, because we have no more an apical anatomy. We can prepare it more without having doubts to create damage ourselves with our instruments. Obviously, when we have a root resorption, you have an unfavorable geometry for the filling. And if you are lucky, such in this case, we can have this invert filling of the root apex. But the most cases, you cannot deal with this anatomy with the classical filling technique with gutta percha and sealer. And we will see how to manage such cases with adapted root filling techniques, other than use enhanced attention to the chemomechanical debridement, as we have already underlined. And again, in these cases, the so big preparation, we reduce the taper of the preparation. And the classic Schilder technique, vertical condensation, is more indicated to have a better control on the filling of these root canals. Other micro-CT reconstruction in which it's very clear this concept of the apical root resorption, destroy of the anatomy with which we have to deal. And we like to make a difference in this case. In these extreme cases, for example, this lower molar with an accessory root and this bone destruction, if you are able to prepare your apex with even a big size, but with a circular shape, in our clinical practice, even if it is 100, 120, you can manage filling with gutta percha techniques. A gutta percha cone, master cone, and sealer, controlling the extrusion, that it's the biggest problem in this case. But if you are able to adapt a round cone in a round preparation, you can perform these fillings with the gutta percha techniques. And you have good results. 1 year, 2 years, you have the resolution of the pathosis. In these cases, you can use also MTA, as we will see in other cases later. But even if in bigger sizes, we prefer to use gutta percha and sealer because it's simpler, much easier to perform. And all these cases follow this concept. Big preparation, even more than 100, 120, but with visual gauging, a round preparation, and we can perform a three-dimensional filling and obturation with good healing at long-term distance. Another case, a very big periapical lesion arising in only a few days, because probably destruction of bone, cortical bone, and the healing after 2 months is very, very nice, very fast, because the cortical bone has been reconstructed by our treatment. All these cases followed the same concept. Correct size of apical preparation. If we feel the clinical situation that we can manage with a round apex with round instruments and fit very well a round gutta percha cone, we manage it with the gutta percha techniques. Instead, we will show other cases in which we have to fill these root canals with a different technique.
We have seen till now that we can manage our clinical attitude to try to adapt our techniques using the classic obturation that is at the moment the gold standard to these difficult situations in which the anatomy of the apex has completely changed. But we can even try to have a different approach, changing our technique in this situation and trying probably to have a different approach. So changing our work to manage these difficult situations. There is here another case that could be similar to the other that we have seen till now, with a really, really big root canal and a big apical dimension. It is a young tooth, and it has been tried an apexification, or better, as we can see, a regeneration of the apical pulp. But after a little bit of symptoms were developed, we decided to go through the normal root canal treatment that was performed with a classical technique, and we can see this is the already cleaned root canal in the apical end portion, and the big dimension of the apex with a final preparation to 70. We have to remember that in this case we had a real thin root canal wall, as we have seen from the radiograph, so 70 was a real a big preparation. But even if it is a big diameter, with this kind of manual preparation under the apex locator, we can see that our main goal to have sound white denting on our instrument, it was not respected. So we know that probably the measured diameter of this root canal, that is probably not is possible to be seen in the radiograph, is not enough. And so we touch with our instrument only the minor diameter. We try at this point if we have a fit in the apical region with a taper 2 root canal instrument of the same size, and there was a contact, probably, let's say, what was called a gouging of this file. So we completed the preparation knowing that we had an oval shape of the apical region contacted by our instrument probably only on the minor diameter that we can see. So at this point we enhance the activation of the irrigants, so we try to have a better diffusion and activation of the irrigants more than usual. We can see with the microscope the apical foramen, around 22-23 millimeters length of the tooth. It is a straight root, so we can see directly with our magnification where we are working. At this point we perform the drying of the root canal with pepper point. We have to check if there is any kind of bleeding or presence of exudate in that area. And this is the different way in which we act. We try to clean with our device, and then we use a sealer that is, this is a bioceramic kind of sealer, in which it is not the gutta percha that had to push that material, but it is the material itself that will seal, because it is an MTA based material, let's say a silicate based material that will set with a little expansion, create a real seal of the root canal by a chemical action. And we know that this kind of silicate based material like MTA, they work really, really well when we have situation of perforation or of apical dimension really big, when we have in surgery some retrograde preparation. This is the cutting of the cone that is not aimed to push in any case the cone. We have only to cut coronally, and we have to mention that the gutta percha cone is only something that will deliver the material in the apical region. It was of the same size of the last instrument used, so a 70, and we just have used it half millimeter or even 1 millimeter short of the apical foramen, because we want that the real sealing of the dimension of the root canal, of the 3 dimension of the root canal, will be done by this sealer. So this is a change of the concept. There is this is the radiograph of the postoperative. after the obturation with this material. We can see that there is a good control of the working length with our obturation, but of the limits, of the apical limits, let's say. But we have to mention that this is the point of this material, managed really well the control of the apex. And this is the control at 1 month. The symptoms were going good, positively in evolution. And at 6 months, the tooth seems to be going to be in healing. So it will be this a future paradigm shift. We don't know yet, because we need some clinical experiments, clinical studies that will demonstrate that this material can seal better than a classic of what it is conceived, what it is think today as a gold standard, that is a gutta percha plus resin-based sealer or other. So we still have to wait if this will be a real paradigm shift in the future. But today, in difficult, really extreme cases, we can use it. This is a molar with a periapical lesion, a bigger one in the mesial root, with an osteocondensation process that is a normal process that can happen sometime during some development of periapical inflammations. In this case, we have a distal dimension of the root canal that is really big. The problem in retreatments is always to try to avoid and to eliminate in all the isthmus and connection in between the root canals all the kind of old material that is probably can be infected. And this is something that takes really much time under magnification to remove all the material to the apical region without pushing them outside and trying really to clean in a proper way the root canals. We can see that in this case we enhance again the activation of the irrigants. This is a young tooth, so it was possible to unify the root canal, and you can see how oval is in the coronal region, but it was even, as we have seen before, our informations, all the variables that we collect during the work was making us thinking that there was an apical dimension really extended in a buccolingual sense. In the mesial root, we had the similar problems with 3 main root canals connected by isthmuses, probably from the coronal portion, arriving even in the apical region and probably at the apex. So again, we go a little bit faster, seeing the removal of all the material that when we try to grab out from one root canal, we will push in the isthmus this material, and it is really difficult to remove it. It is really a game of patience that we have to play and try to eliminate all the material possible in the isthmus. We use this manual files, headstrong and square K files to try to grab out the material. We can use even ultrasonic activation to move, as we see here, ultrasonic file to move the material and to eliminate it from the root canal walls. But again, it is always something that takes time and a lot of patience. Sometimes it is needed more than one appointment to complete this goal. We see here that even when we think that we have reached a good dimension of preparation, the material is still there compacted in between the isthmus or really is sticked on the root canal walls. So in this case, the problem that we had after the removal of quite all the material, we can use at the same time some mechanical instrument to grab out this material. But at the end of the preparation, our sensation was that in the apical region, these root canals were really extended in a buccolingual direction. So let's go further, and we see that we make a try-in of the radiograph with a try-in of the gutta-percha point, but we decide again to use a silicate-based material, so a bioceramic-based kind of sealer. This is the obturation, and we have to say that in this kind of obturation that we are doing, we are seeing a really fast healing. So we put this slide just to say that we like to follow our lantern on the river even in its evolution. So usually we make even the restoration because we want to be sure that there is a sealing that continues from the apical to the coronal direction. So in this case we make an indirect restoration and cementing it. This is a little bit off topic, but it is just to underline that we want that the tooth should be restored and sealed from the coronal portion to the apical portion with the same accuracy and the same, let's say, assurance of well maintenance in the time. And as I was saying before, even after 1 month, the symptoms were going much better. And after 8 months, there is a good healing, not still complete, but really a good performance of this material. Because it looks like the lesions obturated with bioceramic materials or other silicate-based cement, it is much faster. But again, we have to follow the cases, and let's see if the clinical and in vitro research will give us the justification to use this material extensively in the future. But let's go further. Sometimes we have situations in which we can say there is a really extreme apex. And this is a complex challenge that we have to manage, because what we have seen till now that was throwing in our eyes was something, let's say, that it is different, but arrive in the the apical region. But sometimes the resorption make us to work with an apical limit that is extremely moved on the coronal direction, like in this case, where the root was completely resorped till the coronal portion. But what we think in these cases is that it is a big challenge, but we can do it if in the coronal region we have enough dentin to assure to this tooth a good prognosis in the time. So in these situations we use a technique in which, again, in the distal root it was used a normal gutta-percha point, because it was a case like the one that we have seen before, in which it is possible to adapt our gutta-percha technique to a different situation. But in the mesial root, we can see with the pepper point, we can take an impression of the bleeding, and we can see how it is the shape of the root canal at the level of the resorption here. In these cases, we like to have a barrier that make us a matrix against which we can condense our material for the obturation. That in this case it is again a silicate-based material. So we compact these collagen fibers over the apex. They create like a matrix. They are condensed well. This material is something that is not used in so much in dentistry, but much in general surgery. So we condense over the apex this material with pluggers or with gutta-percha points or with any material or with any instruments that will push the material over the apex. When we feel the sensation that there is a resistance, we can put inside the root canal. This is an old case, so it was performed with the classical MTA. So we can condensate and create an obturation completely done with MTA. When using this material, it is important to manage the dry and wet consistency of this material. So with the pepper points, we can play if the pepper points and condensating the material with big pepper points, even using it on the coronal side of the pepper points. We can use it dry when we see that the material it is too soft, or we can use it a little bit wet when the material is too dry, it's too hard. So in this way we can play with the material and condensate against the matrix. And we see here the final obturation with MTA. In the radiograph it is not something that is really beautiful, because we see that the condensation of the material sometimes shows some incomplete situation, and it's some incomplete area, but here was the apical limit that we were following. The point is that having a good cleaning and having a good sealing, because this material have a real good seal of the of any kind of anatomical area, we see that at 1 year we had a complete healing of the lesion with the formation of a lamina dura around it. So the tooth was finished with a restoration of an overlay, and we followed this case till 4 years ago, and the tooth, it is still there. So this is something that can be an extreme challenge for us when this kind of apex, they are no more apex, they are some other thing, but with a completely different shape, that it is not circular, it is so elongated in the dimensions. So let's go to see another case in which again this was happened by the big resorption in the distal root of this root canal, of this lower molar. And in this case, we use it as a matrix, another kind of material that is a sponge collagen, so it is a little bit harder. This was done because in the distal root canal of this molar it was wider, so we can put directly a big piece of material and push it outside the apex. The technique to be sure that we are pushing the material outside of the apex is to push it with a metal carrier, with a metal plugger, that will give us, connected to the apex locator, the over the apex signal of the apex locator itself. So if we make a little bit wet with sterile solution when we bring it to the place, so over the apex, the collagen sponge, we can verify with our plugger that we are over the apex effectively. And the material should be pushed a little bit to control that we can compact against it the MTA. This is the obturation after following this technique, and we can see here the sponge that is visible on the radiograph and the obturation of the root canal with MTA. Even this case was followed after a restoration with a partial resin composite build-up kind of restoration, we can see here. And after 6 months there was a good evolution of the periapical lesion. And at 3 years we have the tooth still there, completely healed. Another final case of a retreatment in which there was a big lesion on the distal root of a lower molar again. The patency made on the mesial root canals, and we can see in how much big is the diameter of the distal root thanks to the resorption again. We have to always to deal with the biological process. So in the mesial root canals was performed a regular obturation with gutta percha, while in the distal root, and we can see here clearly under the microscope the shape of the root canal down there that is made a little bit circular with our instruments, and then there is a big extension laterally here. we can see. So in this case, we pay a better attention to the activation of the irrigants even in the apical region, trying to make the best possible debridement in that area. And after we perform the best possible mechanical, chemical debridement, we make the classical step to dry the root canals with pepper points. And in this case, we perform the obturation of the root canal without the matrix. It is possible to see directly the material that is put inside the area we want to close. The amount of material should be really small so we can control it really well to avoid overextension of the obturation. And we see that we condense even on the lateral sides of the root canals, canal. We see here, using a plugger in stainless steel, or even pepper points, as we were saying before, to dry a little bit the material and make it a little bit harder. If we see that it's too hard, we can use a pepper point that is wet. Now the consistency of the material should be sandy like this, and we have to reach a dimension, a thickness of the material of around 3-4 millimeters. Not less, because if not, it can lose the properties of sealing the root canals. Final steps in which we control, and here it is after 1 week, in which we have to check if the material is set down with a file, and we see that it's hard, so the MTA has set. This is the obturation, and we see that we have 4 millimeters, more or less. The rest of the root canal can be left for good aperture obturation, to put a post or anything else. In this case, we put the post in that root canal that was the best one to make this. And we see that at 1 month, the symptoms were good, 3 months evolution, 6 months, 9 months. At 1 year, we have a quite good healing, and at 2 years, we have a complete healing of the lesion. So we have had...
Hey Nick, sorry to interrupt you. We have to finish. We arrived at 2 hours lecture.
Oh, sorry, because I was thinking that here on the sofa where all the people were looking at our lecture, it was so comfortable, and so the time was passing so fast. And so it was really, really amazing to having this experience with all of you, all the participants and all the lecturers. I think that this will be the future of spreading knowledge in endodontics and in the scientific world.
And Nick, please let me thank again all the organizers of this fantastic event. We are really proud to be part of this amazing group of endodontists that have made this international Endomaster possible. Thank you very much for your attention, and I hope to see you very soon. Ciao again.